Hi, everyone. Welcome to the fifth webinar in NASTAD's 2017 PrEP Financing and Access series. For today's webinar, we're going to cover consent and confidentiality considerations facing minors and dependents who are trying to access PrEP. And thank you for joining us today. I'm Edwin Corbin Gutierrez, Senior Manager in the Health Systems Integration Team at NASTAD, and I'm joined by my colleague Zach from the Prevention Team here at NASTAD. Hey, Zach.
Hey.
And we have two great speakers with us today, Jennifer Driver and Jason Potter. We've asked our presenters to keep their presentations somewhat brief to have time for discussion. To contextualize today's conversation for new participants, NASTAD's PrEP Financing and Access webinar series showcases strategies that health departments and community health providers have developed to finance PrEP programs, decrease disparities in access to the intervention, and evaluate PrEP access. And so far this year, we've discussed PrEP drug assistance programs in Washington and Illinois. In May, we discussed PrEP directories and online navigation resources with pleaseprepme.org. In June, we discussed Iowa's TelePrEP program. In July, Colorado shared their PrEP insurance and financing navigation training work. And in August, we heard from San Francisco's comprehensive academic detailing program, as well as from the Fenway Institute. On November 1st, we are going to share a new online tool to help PrEP candidates and PrEP navigators compare marketplace health plans to enroll on the best plans available to them for PrEP. And we'll provide more details at the end of today's webinar. You will have access to the recordings of this webinar and other webinars in the series, as well as other resources that our presenters shared with us through NASTAD's online technical assistance platform. The site is nastad.blackboard.com. And you can also email ontap@nastad.org if you don't have an account or run into any trouble. So let's dive into consent and confidentiality.
Thanks, Edwin. So for today's discussion, we asked our presenters to help us examine consent and confidentiality barriers. In particular, barriers facing minors and dependents as they try to access PrEP services. A crucial part of our conversation today will be learning about the various laws, policies, and regulations that are applicable to minor consent and confidentiality for PrEP. We also asked them to share strategies and suggestions on how jurisdictions and providers can use to better understand their state's legal framework. Our learning objectives today are to understand the difference between and impact of consent and confidentiality laws, policies, and regulations, to identify best practices for health departments to ensure young people are educated on confidentiality barriers in their area, to be familiar with the Caecus PrEP Toolkit and how it might be used within your jurisdiction, and to understand resources to troubleshoot confidentiality concerns within jurisdictions. With that, I'm going to introduce our speakers. Professor Jason Potter, pronouns he, him, his, is a graduate of New York University School of Law and an associate teaching professor at Northeastern University School of Law. At Northeastern, Potter is a core faculty member of the school's Center for Health Policy and Law and is a nationally known expert on the legal and policy implications of expanding access to biomedical HIV prevention to vulnerable populations, including underage adolescents or minors. Jennifer Driver, State Policy Director for Caecus, joined in August 2017 as the State Policy Director. In this role, she oversees Caecus's efforts to integrate and engage state and community partners, develops and provides strategic policy and advocacy guidance to state and local partners, and leads research and analysis of the Caecus state profiles and legislative reports. Jennifer began her work in public health examining health disparities in HIV among young people of color in West Alabama. Prior to joining Caecus, she served as the manager of training and education with Welcoming America, where she managed the racial and health equity work for the Immigrant Inclusion Organization. In addition, she incorporated an intersectional approach to immigrant inclusion while providing training and education on race, structural racism, ethnicity, housing, health, and poverty. She examined policies and practices that address disparities related to race, ethnicity, gender, sexual orientation, disability, and socioeconomics. Her previous experience includes working for the National Campaign to Prevent Teen and Unplanned Pregnancy and the Georgia Campaign for Adolescent Power and Potential. She has particular expertise and experience in issues relating to social determinants of health, health disparities, and public policy issues of concern to African Americans and other minority populations. We enthusiastically welcome both of our speakers today, and with that, Jason, take it away.
Hello, everyone. Thank you. Thank you for having me on the panel today. I'm just going to dive right in. I'm talking about consent today. I see consent as a threshold barrier to PrEP, implementing PrEP among underage adolescents and dependents. Just a few basics. So when I refer to the term minor, that's an individual under the age of majority or the age of consent, and that's a state law issue, and it's normally set by state statutes. It's 18 years old for most states. There are a couple states where it's older: Alabama, Mississippi, Nebraska, 19, 21, and 19 respectively. But the term caregiver, I use the term caregiver rather than the word parent. So I use caregiver consent rather than parental consent because it's more inclusive. Because this figure may include a parent, a family member, a guardian, a foster parent, a conservator of the state. So the general rule about parental consent or caregiver consent is that minors can't consent on their own to their own health care. The law shifts that role to the caregiver. So the practical implication of that is that most minors lack confidential health care. But lawmakers, recognizing that in the context of sexual health care would cause delays in care if they required parental consent, created these exceptions to the rule. And they allow minors to consent to specific services like mental health, substance use, reproductive health, or STI care, or to general medical care, depending on the exception. So if we can situate PrEP within one or more of these exceptions, then that helps us achieve confidential access, because that means under most of these exceptions, if they fall into it, then the minor can consent to their own health care. So just a few things about caregiver consent generally. You know, I using anti-oppression principles to show that caregiver consent is an oppressive access barrier when it comes to PrEP. It causes institutional barriers for PrEP access. In the context, we know that tenofovir is not FDA approved. The parental consent requirements on institutional review boards, federal policy, cause delays in research, and we know this, and delays in research and cause issues with FDA approval. So that's the federal component here, but this is mostly a state law issue. Caregiver consent also creates individual and self-imposed barriers to PrEP access. Confusing statutes can lead to prescription delays with providers. Contacting an adult could have devastating, violent consequences for some minors who go to the doctor unaccompanied because they're not, in the context of LGBT minors, they're not out. Fear among adolescents that providers will require the consent of caregivers, even if it's not necessary, could affect the desirability. And studies show that privacy is an adolescent's main concern. So this means that consent becomes a real barrier to PrEP uptake. Caregiver consent also creates ideological barriers to PrEP access. Caregiver consent assumes that adolescents lack decision-making capacity on their own, and that parents always act in the best interests of their children. So let's take a dive into these exceptions of minor consent laws. All 50 states plus the District of Columbia have minor consent laws that are exceptions to the general rule, but they vary from state to state greatly. To be clear, no state statute expressly allows minors to consent to HIV exposure prophylaxis, but it can be implied in some. So there are three basic types of STI consent or minor consent laws. The first pertain to specific conditions like STIs, like addiction, like mental health, like pregnancy, and would allow a minor to consent to care or treatment relating to that particular condition. The second are STI or status-based consent laws, and those would allow a minor to consent to general medical care, not with relation to specific conditions, but general care if they fit a certain profile. For example, if they're homeless. Some states allow homeless youth to consent to general medical care. And the third type are emergency consent laws, where parental consent is implied. That doesn't mean that the minor can consent, but parental consent is implied if the minor's health or life is in jeopardy. So I'm only looking at a few of these types of statutes here, but we're going to look at STIs first because of all of the different types of statutes or exceptions, STI consent exceptions are probably the most likely avenue to lead to confidential PrEP access. Under these statutes, a minor can consent to certain care relating to STIs. The term in the statute might be STDs, venereal diseases, or reportable diseases. All states in the District of Columbia permit clinicians to rely on a minor's self-consent to STI testing, and most explicitly include treatment. Now, because there's so many variations from state to state, I had to develop a framework for understanding the variations. And so that could be useful for everyone on this call. So I came up with 4 basic considerations that we should think about, 4 basic dimensions of any state's law. The first is a disease dimension, an age dimension, a notification dimension, and a scope of care dimension. So basically all state STI consent laws are going to have these dimensions, and these affect whether PrEP would fit within the statute. So the one that's the most that affects it the most is a scope of care dimension. So let's take a look at the scope of care dimension. So there are 3 basic types of statutes. There are narrow statutes, there are intermediate statutes, and there are broad statutes in terms of the language of the statute. So under narrow statutes, minors can consent to diagnosis and treatment in the case of an actual or suspected exposure. Diagnosis and treatment. Well, it doesn't explicitly talk about PrEP, but can we infer that PrEP is a treatment? HIV testing and treatment are clearly contemplated, but is PrEP a treatment? There's an argument that it is a treatment, that it's a prophylactic treatment, but it's not treating a condition. So it's unclear, and so clarification is needed in these states. And these are most states. Most US states have narrow STI scope of care dimensions. So there's advocacy that needs to be done in these states. One state, for example, is the state of Florida. The state of Florida statute says providers may examine and provide treatment for sexually transmissible diseases to any minor. So in here, unless the statute defines treatment, it's unclear, and I would not advise you to prescribe PrEP without parental consent pursuant to a narrow statute like this. The second type is an intermediate tailored statute. This is a statute that says minors can consent to care for or prescription for an actual or suspected exposure. So is PrEP, again, is PrEP a treatment? And clarification is also needed because it's unclear what care means. So let's take a look at an example, Indiana. An individual who suspects the individual has or has been exposed to a venereal disease is competent to give consent for medical or hospital care or treatment of the individual. Medical care of the individual. It seems like PrEP might fall into that. So in states that have intermediate scope of care dimensions, then you're on the right track. And then there are a few states, 8 states in particular, that have broad statutes, and they allow minors to consent to testing, treatment, and preventative or prophylactic care. Because PrEP is preventative prophylactic, then minors can self-consent in these states. One of the newest states to have this is the state of New York, which just passed a PrEP bill. We can take a look at that. Here's New York's new statute, or its amended statute. Each health district shall provide adequate facilities for the diagnosis and treatment, including prevention services of persons living within its jurisdiction who are infected or at risk of being infected with an STD, and that STD definition includes HIV now. The one thing I would say about this is that it says including prevention services. Well, it's not really a service. I mean, a service is part of PrEP, which is a multidimensional treatment regimen or multidimensional regimen, but it's not really a service. So that would be my one criticism of the statute. So those are STI consent statutes. Again, there's broad, there's narrow, there's intermediate ones. So as you take a look at your state statute, try to determine what the scope of care dimension is. Is it broad, intermediate, or narrow? Now, next, status-based consent laws. So these allow minors to consent to general medical care. And if a minor's status coincides with what's in your law, then a minor can probably consent to PrEP. So the ones that are the most, now states have great variation in these status-based consent laws. As you can see, there's all sorts of statuses that would allow a minor to consent to PrEP. A couple of them, the most notable are the minor who is living separate and apart from parents and is financially independent. Some statutes don't specify the amount of time that an unaccompanied minor would have to be living separate and apart, and how financially independent they have to be. So that clarification is needed there. But if you're dealing with an unaccompanied minor, then this is something to ask about. Another one are the homeless or homeless minors. Homeless youth statutes exist in Arizona, Florida, Illinois, and Missouri. In Florida, unaccompanied youth can consent to medical diagnosis and treatment, including preventative care. But the one catch of this is that the statute requires documentation of a homeless services professional. And finally, the third type of STI consent, or excuse me, of consent statute is emergency consent laws. Now, these allow healthcare provider to treat if and parental consent is implied. The one issue, this could be useful in the PEP context. After an exposure, when time is of the essence. But the problem, at least in Florida and a number of other states, is that they do require parental notification after the fact. In Florida statute says notification shall be accompanied as soon as possible after the emergency medical care or treatment is administered, and then it requires a notation in the hospital records, and that the records shall be open for inspection by the caregiver. So in Florida, furnishing prophylaxis, PEP or PrEP, pursuant to this exception, compels one confidentiality breach and permits subsequent breaches by the caregiver. So it doesn't really suit the end of allowing a minor to consent to PrEP confidentially on their own. So my recommendations in terms of things to think about would be, first, try to identify opportunities to expand PrEP and reasonably leverage existing consent statutes to achieve that end. To do that, you're going to have to study your state's consent statutes using a framework like the one I've just explained, and develop sample PrEP consent policies for provider use. This area is extremely confusing for providers. So to the extent that you can provide them with a sample policy that's based on your state's law, that can be useful. And I think all in all, it's very important to build momentum to expand access through incremental legislative and policy changes. Every state should have the word prevention in their STI consent laws. And lawmakers and policymakers should be encouraged to also define the word treatment, which might be an easier fix than amending the law, just adding expanding the definition of treatment to more clearly contemplate PrEP. I've included some more resources, and I don't know if the organizers are going to send around the slides. My article, PrEP in Our Youth, explains all of this. And the Caecus includes has a sample PrEP policy that I mentioned in my recommendations. And a lot of these issues are discussed in a Culp and Couchy article that I've included here. And if anyone has any questions, please feel free to contact me. Thank you very much.
Thank you, Jason. Jennifer, take it away.
Awesome, thank you. Thanks, Jason, for setting us up for consent and confidentiality. So as mentioned, I'm with Caecus, and really quickly, just a quick background on us. We're really rights-based, so adolescent rights focused, so making sure adolescents have the access and information that they need to stay healthy in their lives. And so when diving into confidentiality, the importance of providing confidentiality protection for adolescents and young adults seeking sensitive services, it really cannot be overstated. Numerous healthcare professionals and organizations have formal policy statements supporting the importance of confidentiality. Many of these organizations, among others, include the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, the ACOG, and the American Medical Association. And going through looking at confidentiality, what we found is the main way that confidentiality is breached is really through billing and insurance claims process. And that really has a serious consequence because minors and young adults, when this information is breached, really encourages or discourages access to healthcare services, which leads to negative health outcomes. And although there are really some benefits to having parental involvement in adolescent health care, situations exist in which parent notification could place adolescents at risk of verbal or physical abuse or conflict. And so what this leads to is underutilization of essential healthcare services by adolescents. There was actually a study that looked at and examined whether or not young people, when their parents were notified, would they seek out healthcare services, and the majority of young people actually said no, that they would not seek out healthcare services, and they would actually forego STI testing as well. And so it's really, really important that we keep confidentiality in the forefront of our work. So state laws allowing minors to consent to certain services don't necessarily guarantee confidentiality. Some states have laws that specifically prohibit providers from disclosing information about certain services to parents. Other states provide physicians with direction to inform parents, and even if the healthcare provider chooses not to share or is legally not allowed to share the information with the minor's parents regarding sensitive services received by the minor, the breaches of confidentiality, like I said, really can occur through the explanation of benefits, or the EOBs. So 13 states have provisions that serve to protect confidentiality of an individual's insured as a dependent. 5 states allow individuals insured as a dependent to request confidential communication from the insurance provider through a written request. And 2 states have confidentiality protections specific to EOBs. And so if I was to make a policy recommendation or start thinking about recommendations, I would really look at those type of provisions where the confidentiality is really specific to explanation of benefits, because that's where it's typically breached. 6 states explicitly protect the confidentiality of minors insured as dependents, and 3 states specific protections for minors for seeking STI treatments. And so we're gonna go a little further and look at some examples of states. I saw a question around Florida, so I just wanted to highlight that Florida is one of those states that has protection for minors for dependents, but it's confidentiality for STI treatment. And so if you were going to go and look to see where maybe some gaps would be, it would be kind of in that billing process. So if you were to look at states like New York and Wisconsin, the EOBs are not sent when there's no balance due. So kind of that's one positive thing. If we're looking at how explanations of benefits can be sent to patients, New York and Wisconsin is another one where the actual patient or the dependent themselves can reach out and actually get that information, so it doesn't have to go through a parent. And so I just wanted to flag a couple of other ones. I know that Jason had mentioned Florida. Iowa is one where minors can actually consent to HIV testing, but the test, if the test is positive, and a parent or guardian must be notified. So even in states where there is consent, confidentiality can be breached, just basically through the explanation of benefits. And so the takeaway from kind of the confidentiality is really looking at how EOBs are sent and reported, and how if young people are aware of that information. So as we mentioned, Caecus developed this PrEP Toolkit. So in March of 2016, we convened a kind of this group of experts to work to address issues surrounding PrEP delivery and kind of the consent and confidentiality. Inside the toolkit, it's broken up into 5 different sections. So the first section really looks at clinical tools, and this part offers a background of information for PrEP and the CDC PrEP guidelines and other tools to really help people getting ready to offer PrEP. There's also a really strong clinical reference sheet to break down kind of the clinical components into simple kind of reference tools. And there's also a guide to really help taking sexual history. So for clinicians who may not be really experienced with that or don't routinely conduct sexual histories, that's a really strong area to take a look at. It also does it from a culturally sensitive approach and has suggested questions are included in that section as well. When we look at section 2 of the toolkit, there's a lot on billing, so to really help for billing and coding for young people to afford PrEP, and really helps clinics really maximize that. In section 3, there's a strong component on HIV stigma and the social determinants of health, and it allows those using the toolkit to really check their bias when offering services to young people. So it's everyone from frontline staff to physicians who are implementing this. The fourth part of the toolkit really looks at the youth HIV laws and policy, and so that's where you're going to find the state policy table. And so if you're looking to see whether or not or what your state statutes are as it relates to minor consent, confidentiality, and criminalization of HIV, you can go into that chart and click on your state, and it will pull up your exact statute for minor consent, confidentiality, and criminalization of HIV. And then lastly, in this section is really the additional resources. And so we have pulled a lot of Jason's research in this toolkit. As he mentioned, there's the sample policy or the model policy that we often reference for those who are looking to improve their state policies. And we also lean heavily on Guttmacher, the good reference for this as well, to figure out kind of what your state's confidentiality policy is, which my guess is there aren't a lot of strong ones. So when we start looking at policies, kind of how to tweak and shape and enhance your policy. So I'm happy to show you or walk you through a policy if you're interested in that. Or how to strengthen your state policy, and then also how to find your policy as it relates to confidentiality among youth youth. And so with that, I will turn it over and open it up for questions.
Great. Thank you so much, Jennifer. And thank you, Jason. Just a reminder to our participants, enter your questions using the Q&A function, which is on the menu bar. We have a couple of questions that have already started coming in. Zach, do you want to take the first one?
Sure. So Jessica from New Jersey asked where we can find state-specific statutes such as New Jersey?
Sure.
Go ahead, Jennifer.
I will just highlight one. So if you go to the Caecus PrEP Toolkit that I referenced, in the section 4 of the consent and confidentiality policy, you can scroll down to New Jersey. If you just click it, it has your statutes there.
Jennifer, someone's looking specifically for your PrEP toolkit. So if you could just detail again, we are going to provide it after this webinar, but where they might be able to find it.
Sure. It is available on our website. It's caecus.org. So www.siecus.org. So if you go on the home page, on the left-hand side of the home page, it says Caecus PrEP Toolkit. You can click it right there, and it's available right on the home page. You can also reach out to me, and I can just email it to you as well. And my email is jdriver@caecus.org.
Okay.
And if anyone is interested in a list of all of the state consent laws, I can provide tables to you if you email me at j.potter@northeastern.edu. Also, my article, PrEP and Our Youth, Implications in Law and Policy, has a great deal of tables in the back that have all of the state statutes dealing with consent.
I think some folks are interested in understanding who is currently working on this policy issue. Are there any jurisdictions that you know of that are currently working to actively address this, and how are they doing in that work?
Is this question dealing with consent or confidentiality EOB? I can address it from the consent side. On the consent side, I know that Massachusetts has a PrEP bill that was introduced by Senator Julian Cyr, and so you could anyone could find the text of that proposed statute. It basically just adds the word prevention into the already existing STI consent statute. Just like I discussed in my presentation. So Massachusetts is one, and New York is one that just amended theirs.
A follow-up to that, based on what you've seen across the country, what are the easier mechanisms that you can think of states could follow to ban the consent laws in the state? Are there? You mentioned, for example, there might be opportunities to expand the language so that includes prevention, but then also there's other tactics. Yeah.
Sure. So yes, the first thing is an amendment to add prevention and to add the phrase risk of exposure, not just exposure, but risk of exposure into the statute. So that's an amendment to the existing statute. There's also the opportunity to, because almost every state uses the word treatment, many states use the word treatment in the statute. If there's no definition of treatment in the statute, many there aren't, there's no definition. If you could persuade policymakers or legislators to add a definition of treatment that includes prevention, that would expand access. Or if there is a definition of treatment, to tweak that definition a little bit, so prevention is also, or risk of exposure, or prevention is added. Those are the two incremental changes that one could make to expand access.
In cases where the language is not as favorable as one would want, and it's open to interpretation, what are some steps for states that cannot change the statutes? What are some considerations, action steps that you think they should take?
That is one of them. So I think it's important to think outside the box and not get married to the STI consent statute, because there are these status-based consent statutes that I would say a good deal of unaccompanied minors might fall into, like the exception of living separate and apart and financially independent. I mean, there's a lot of interpretation to be had under that particular exception. But there are I would suggest study the status-based consent laws, and you can draw a policy, a sample policy based on your list of statuses that would allow the minor to consent. So that's how I would approach that. I would try to think outside the box.
The other thing that I wanted to make sure that I highlight is kind of from policy to practice. I think there are a lot of states that are, or there are some states that are working on this, and I think Jason mentioned some, and there's also Connecticut that's doing this work as well. But taking it into practice, looking from the youth perspective, making sure that youth know their rights. Very seldom do youth actually understand the whole explanation of benefits and knowing what your parents will find out. And there's some really great resources to help youth understand confidentiality and consent. So there's one from the Black Women's Health Imperative that Let's Talk About PrEP. Under the resource section of the toolkit has a lot of for patient knowledge, but really helping young people understand their rights as well and understanding consent and confidentiality so that they're being able to kind of take this in their hands as well.
Thank you. In terms of communication with minors and dependents, what are some successful communication strategies that you know about in communicating these complex laws and regulations to consumers?
Sure. So California actually did what I thought was pretty cool. They had a social media campaign. California and New York, actually. New York did this as well. Had a social media campaign to really not only inform young people about PrEP, but also about their rights around PrEP. California took it a step further and actually talked about consent and confidentiality. They had a text messaging system where you could text a number and get information back. And they also had an app that you could download and kind of this Know Your Rights campaign. Those are two examples that I've kind of witnessed that I've seen. Ooh, sorry, one more. I mentioned the Black Women's Health Imperative. They also have a hashtag that they have done for young people, or kind of young and old alike, I guess, to where you could do a hashtag and someone could respond, or you could find out information about kind of the Let's Talk About PrEP.
Thank you. What exists to address minor safety concerns?
Julie's asking about what are the safety concerns. I think there are a number of them. First, revealing a request for PrEP may reveal that the minor is sexually active. It may reveal or purport to reveal sexual orientation. And these are things these are precisely the concerns and fears of privacy concerns of minors are exactly the reason why we have these exceptions. Because in the matters of sexual health care, science shows that adolescents would sooner not go to the doctor than have them contact their parents. So I would say that they're inherent in there are some safety concerns. How to address that? I don't know. I think it's work with the consent laws.
What kind of arguments and evidence have been successful to be able to move those statutes along?
I'll mention one. Under STI consent statutes, there's an illogic that really can result because an HIV negative adolescent or minor who cannot, in the majority of the STI consent statutes in the country, cannot consent to PrEP. But the same minor of the same age, under the same statute, could consent to the same drug, tenofovir, if that minor was HIV positive. Now, what are we saying here, right? So there's a logic that results from the advances in biotechnology that they couldn't anticipate back then, and that's a convincing argument, I think.
Are there other legal and regulatory issues that may need to be addressed that we haven't covered?
I think one that I can think of right off the top of my head are the parental notification. I don't think we've spent enough time on parental notification because there's parental notification provisions in quite a few laws, and emergency consent laws are just one, right? You might think that you could provide PrEP under emergency consent law, but then you realize that you have to contact the parents afterwards. So you have to really read and anticipate and know what the notification requirements are. I mean, this is a consent issue and it's a confidentiality issue. It's a really important issue.
Thank you. Jennifer, on the explanation of benefits, even after a young PrEP candidate, called their insurance company and got them to verbally say over the phone that they would not send an explanation of benefits home, the process itself was complicated for both the client and a navigator trying to help them. Are there any best practices there or any advice for PrEP clients?
There are a couple of things I think that go along with that. So it's one where we are creating policies and looking at these confidentiality laws, but it's happening on one end, but we're not informing and talking about best practices when it comes to like insurers, right? So no one sits down with the insurers and thinks about best practices for minors in this conversation. It is a very tedious process when minors try to go and they actually have the ability to get their EOB from a provider, but they're not getting it, or they're getting kind of the runaround or the barrier. They get frustrated, right? And they don't continue the process. So I think from a policy standpoint, or even from kind of an in the field or the practice standpoint, not only working on policies and changing them, but also working across systems, right? So we're working across with the insurance companies to inform them. Now that seems like a very lofty goal, and we're talking about educating insurers there. But I think it's imperative that we're doing both. And again, it goes back to having folks understand their rights and being able to advocate for themselves in this process. We've done a lot of work with young people on how to navigate the insurance companies, right? And how to navigate understanding kind of your rights and getting your EOB and understanding what's going to happen, or like what your parents will or will not see, or when your EOB will come and what's actually on that. And so it's happening at the policy level. It's happening and educating young people. But the one area that we really haven't done a great job is bringing other groups that are really impacted by this, like the insurance companies, to the table. And it's one that people just kind of leave out. But I think it's really important.
Thank you. And we have, I think, time for a couple more questions.
I like this one. Do you mind?
Yeah, would you read it?
Walgreens. Oh, yeah, sure. It says, FYI, we've partnered with Walgreens regionally in Tampa to streamline the insurance process. We write the prescriptions and give a small amount of information, insured versus not. And the pharmacy actually works with the PAP, or first copay card. It's gotten to be very streamlined for us. We thought there would be a lot of patients who couldn't use the particular pharmacy, but we haven't seen that. And the Walgreens rep has been very gracious and helping other pharmacies. I love that. I think that is amazing. I can give more information, but this comes from Diane, but I think that is one of the things that I'm talking about for how we're working with different groups, especially like Walgreens or CVS. I think that's wonderful.
Yeah, so it's an example of a new partner coming in to do some of that navigation and education and kind of streamline those systems. That's a great example. Thank you. Yeah.
Daniel Davidson from Connecticut has indicated that they are currently working to change some of their policies, and so that'll be a jurisdiction that we continue to work with and watch for best practices that we may be able to replicate throughout the U.S.
Great, thank you. We touched on the navigation and education, empowering clients around these issues. And Jennifer, you mentioned the workshops that Caecus has been leading. Kind of along the same lines, are there other promising practices that you could share with everyone?
Yeah, so the one thing that I was saying that we were doing is we were working with a lot of folks from ACOG on this. and the challenge was they weren't seeing a lot of minors, so we were talking to pediatricians about this. And so what we found is kind of a gap in knowledge on how providers or physicians are really responding to young people. And so in this toolkit, that's one of the other parts of education outside of consent and confidentiality that we've really been working with or working on is around working with physicians and kind of clinical staff in response to minors.
Great. Thank you. Well, with that, I'm going to thank both of our presenters. Our next webinar is going to be November 1st. We are going to do a quick walkthrough of NASTAD's new PrEP cost estimator. It's a calculator that helps PrEP candidates and navigators figure out the best marketplace plan for them, taking into account both discounts, out-of-pocket expenses, and copay assistance programs. It's going to include both federal and state marketplaces. We'll send out more information over email, and all of the resources that both of our presenters have shared throughout the webinar will also be included in that next communication, as well as the webinar recording. And so just a huge thank you to the two of you for the webinar today and for walking us through this complex but very important topic. And thank you everyone for joining us. We will see you next time. Have a good one.
Thanks so much.